Oh, there we go. I didn't even do that. It heard
I
me.
gotcha.
Okay. Perfect. There you go. Kelly and I are tag teaming here. So hopefully it looks like everyone got on. I think I'll check my email as we get started just in case we have anyone who the link goes directly from Kelly's Zoom and it sometimes gets caught in spam. So I'll check just in case we have some folks who are unable to find it. I am trying to see if Lexi's on. Noah, do you know? I'm sorry, and I don't think she is.
Don't
You happen to
see
see
her on. Let me
Okay.
text her and see
Okay.
if she's planning on hopping on today.
Okay. We'll go ahead and just get started real quick. And as you guys know, we always like to start all people are empowered to live, love, work, learn, play, and pursue their dreams as we start our October, I almost said November, October DDRS advisory meeting. I just wanted to share hopefully you guys have seen the new website is up. I guess not necessarily new. We had a website, obviously, but our reinvented website. Just wanted to share. I know this slide's a little blurry, so I apologize about that. I realized that this morning, but just some of the new logos and colors that we're using on the website. Just wanted to highlight that. And I will start as Lexi's getting on just with we have a very full agenda today. Welcome, a video. We have an employment video that I'm going to introduce that I was actually able to embed into the slides. So hopefully cross your fingers that my technology works. And then Christina Commons is here to give us a BCDS update. And then hopefully Holly has saved her voice because she has lots to talk about through the rest of the agenda with things coming out and with beats. So we'll jump right in. I'm going to see, I might just go ahead. Noah, did Lexi respond to you? And it's okay if not.
I just texted her.
Okay. Okay. I'll go ahead and get started just because I know we have a pretty full agenda and I don't want to hold people up if that's okay. I'll do a quick roll call, and if I forget anyone, I'm going to do this off of memory. So just let me know. We have Laura Fife, looks like. You don't have to say anything, Laura. I just saw your face. We have Kim Han here, correct?
Here.
Jim Wiltz.
Here.
Ian Titus.
Here.
Kelly Mitchell.
Good morning.
Noah Upchurch. Noah, you're on mute, just FYI.
I'll let you know. Lexi responded that she's having trouble with the link. If you
Okay.
could send that her way.
Yeah, I'll go ahead and do this and then I'll turn it over and then I tell her, just give her a quick and I'll resend her the link. We have, let's see, I'm trying to think. Sean Bolton.
I'm here. Good morning.
Morning, Sean. Loretta Springer.
Here.
Hey, Laura. Melissa Keys.
I'm here.
And we have Tom, who is filling in for Kim.
All right, buddy. Apologies for the webcam issues. I don't know what's going on.
No worries. I know it's there's been some other people that have had some issues, Tom. Let's see who else. And we have Reagan.
Good morning.
Hello, Reagan. And you're filling in today, correct?
Yep, filling in for Carrie.
Awesome. Perfect. And let's see, I'm just looking for the members. We have some state staff as well, just on as supporting our staff. Christina Commons obviously is here for BCDS.
Good morning.
I'm looking to make sure I got everyone. Did I get everyone? Thank Holly. I know you're supporting us here, but given lots for the presentation from Beat. So I will go ahead and get started. I'm going to share this video, cross our fingers. This again is a video as we were working with one of our partners on revamping our website that we created around employment. So I just wanted to highlight this. This also is on our website. So give me someone, if they don't mind giving me a thumbs up to make sure that the sound is working. Hopefully, I think I hit the right button. So I'm going to see if this works. Perfect. Yay. Okay.
For so many of us, work is expected. Our job is where we spend almost a third of our life, where we develop lifelong friendships. It's a part of how we define who we are. But for people with disabilities, work is frequently celebrated as a triumph, a monumental achievement. And yet, people with disabilities view a job as an important and expected part of their everyday reality and want the same employment opportunities as anyone else. In short, employment is for everyone. For decades, Many people with disabilities, including those with intellectual or developmental disabilities, have been encouraged to work in sheltered environments. In these sheltered environments, the work is usually very repetitive, typically pays less than minimum wage, and separates people with disabilities from wider society. But over the last several years, many states have begun prioritizing services that support employment for people with disabilities in integrated workplaces that pay competitive wages. Aided by advancements in technology and an evolving job market, more people with disabilities are finding success in the same job opportunities as people without disabilities. The Indiana Division of Disability, Aging, and Rehabilitative Services is fully embracing a focus on supporting people with disabilities in integrated workplaces that pay competitive wages and transforming the way everyone views employment for people with disabilities. Maybe the best way to put it is, DDRS and our partners used to ask people if they wanted to work. Now we're asking them where they want to work. In the past, there was a misconception that people with disabilities couldn't safely work alongside their peers without disabilities. This resulted in many job seekers with disabilities entering segregated jobs paying below minimum wage or deciding to remain unemployed. Today, we know it's best to not only encourage employment for people with disabilities, but make it an expectation. In sheltered work environments, there was a common misperception that people with disabilities could perform only minimally challenging work. But we now know individuals with all types of disabilities have successfully obtained rewarding jobs with good pay, even advancing in their careers, and all while working alongside their peers without disabilities. Historically, some parents or guardians have also had concerns their loved ones will lose their disability benefits if they earn a competitive wage. But financial planning and information about how employment affects benefits is readily available for job seekers with disabilities. And in general, people with disabilities will always make more money by working. One stigma we work to overcome with employers is the perception a job seeker with a disability may not be able to perform the work or that it will be costly for the employer to prepare the workplace for a person with a disability. But accommodations don't have to be expensive, and many are free. What's more, employers should expect the same level of performance from employees with disabilities that they expect for all of their employees, with the right accommodations if needed. And frequently, these accommodations can increase productivity for all employees. When people with disabilities find employment, it's always a good day, but it's also just a day, the first of many for people who simply want the same opportunities and fulfillment as everyone else. Plus, a little cash for groceries doesn't hurt either.
Okay, thank you guys. I like that video because the question is, where do you want to work? Not a yes or no question of do you want to work. So just wanted to highlight that.
Hey, Jessica.
Yeah.
Sorry, Kate just messaged. She's having trouble with the link as well. If you could email her.
Yep. Yeah, I'll do that. I haven't had a chance to do that. Let Lexi know. No, I can't do, it's hard for me to do both when I'm trying to do it. So just tell her once Christina starts, I'll go ahead and send those links. Thanks, Melissa. Okay, I'm gonna move right along. Christina, I'm gonna turn it over to you and I'll run the slides. I'll try to follow your cadence, but just give me a shout if you need me to.
Okay, just verifying that everyone can hear me okay. I don't know why it looks like I'm in the dark in here, but lighting is what it is when you are off-site. So good morning, everyone. As Jessica mentioned, my name is Christina Commons. I have the absolute privilege of being our Bureau of Child Development Services Director here in DDRS. And we're going to present some information today on our First Steps program. When I met with Self Advocates of Indiana last month and was talking about this presentation and what would be meaningful for this advisory board, we talked about kind of taking a step back and rather than making the assumption that everyone knows what First Steps is and what we do. So really wanted to start off with First Steps is Indiana's early intervention program. We are a federal entitlement program under IDEA, or the Individuals with Education Act. And we are Part C of that law. So a lot of times people don't understand that we are an educational program, but are embedded in our Division of Disability. We serve infants, toddlers, and their families statewide in all 92 counties in Indiana. We have 9 state staff in central office. As of yesterday, our team was fully staffed, so that's exciting. We have really a brand new team within the last year. I think all but 2 positions have changed over. And again, we're available in all 92 counties. We have 9 local regional offices that we call systems point of entry that are that first touch point for First Step services. We those 9 systems point of entry, I hired over 250 service coordinators. Every child and family is entitled to a service coordinator and is assigned one at referral. We do have eligibility team members that are also embedded in those offices. They're either employed or contracted with those agencies to provide free and appropriate eligibility determination. We also have 43 provider agencies statewide that deliver IFSP services to children and their families. They also hire or employ 1,800 providers that provide developmental, occupational, physical, and speech therapies. We also have 100 independent providers, which include nutritionists, social workers, psychologists, audiologists, ophthalmologists, and interpreters. And we do receive over 31,000 referrals annually. Next slide, please, Jessica. This slide before you is a sneak peek at what I've created for worked with our Interagency Coordinating Council, which is the advisory board over First Steps, for their governor's report, and also for our quarterly financial review with Secretary Robe and the public. And I'm really looking for your feedback today on the accessibility of this slide, as well as just is it visually appealing? Does it make some sense? So we'll go over some of the data that's presented here. All of the data on this slide is for a quarter, the first quarter of state fiscal year 26, which includes July, August, and September of 2025. And before you just have a little blurb about what is First Steps. Like we discussed, First Steps is a family-centered, locally based, coordinated system that provides early intervention services to infants and toddlers with disabilities or who are presenting a developmental delay. And then all of our First Steps agencies come together to provide families with support in learning therapeutic interventions. We coach families so they can continue those therapies throughout their daily routine. We are showing you the increase in the number of children served year over year from state fiscal year 22 through state fiscal year 25, and then year to date for state fiscal year 26. And we received 8,300 referrals within the quarter statewide. We had 17,000 children served, and we provided 193,026 family visits over that quarter as well. Wanted to provide you with some data on our referral sources. So the number one referral source historically and continues to be our medical and health services providers. So those would be our pediatricians, our NICU providers, any specialists, etc. And the next referral source are families and parents themselves. So 62% of our referrals are coming from the physician, and then almost 24% are coming from parents. We do get referrals from our Department of Child Services. So those children who have been found in need of services through the child welfare system, those also get referred to us. And we've received 11% of our referrals have come from that source. We also receive referrals from childcare, and then our early intervention providers and professionals that are in homes with families also help make referrals for siblings of children that we're seeing. As we discussed on the last slide, the services that we deliver through those provider agencies are developmental therapy, speech therapy, occupational, physical therapy, and then all of those other related services. So the other related services only make up 0.4% of all of the services we've delivered in this quarter, but there's a fairly equal distribution of services delivered between developmental, speech, and occupational therapy, and then just a little bit less in our physical therapy. And then also providing you with some data on the children who exit our program. What is not available on this slide, but I will do this in the future, is adding the number of children who exit without an IFSP. So we have the total number of children exiting the program in each month, and then the number of children exiting with an IFSP. And then you have the number of children transitioning to school, which I think is really important because that's one of the missions of our program, is to decrease the amount of children who are needing special education services after age 3. And then what's even more important are those children who are exiting with their outcomes met prior to age 3. And that is that number there. So the number of children transitioning to school and the number of children exiting with outcomes met are in that number of children exiting with IFSP. So they had those children had an IFSP and exited. We're just showing you where they went after they exited.
Can you tell us what an IFSP is?
Yes, absolutely. Actually, I think Jessica might be the next slide, or we could maybe go forward a little bit. We'll come back to these two slides. I created a slide on what the differences are between an individualized family service plan. So that's what the IFSP is, and an IEP, an individualized education plan. And the biggest differences are age ranges. So our individualized family service plans are for children birth to age 3. And then when they transition to special education or receive special education services later in their educational path, those services are for children aged 3 to 22. For an IFSP, we focus on that whole family and what their needs are to support their child's development. With an IEP, that school is focusing on the educational needs within a school setting. So it doesn't mean that that child doesn't still need some additional services outside of that school, but what do they need to be successful in their learning? And that's what that individualized education plan is all about. The environment that we provide our IFSP services is that natural environment, so like home or community or childcare center. The setting for an IEP is the least restrictive environment, which is inclusive of classroom with peers without disabilities to the maximum extent possible. But we do know that some children learn best in a more restrictive environment than that. But the goal is to provide those services in the least restrictive environment for the success of the education of that child. Through an IEP, the primary goal is to address developmental delays across multiple areas, including physical, cognitive, communication, and social emotional development. With an IEP, the primary goal is to provide special education and related services to meet that child's educational needs. Again, that may not include physical therapy if the child is able to be successful learning in their classroom without that therapy. The IFSP, the team includes parents and service coordinators and early intervention providers. The team includes within IEP, parents, teachers, school district representatives, and other specialists. In both instances, families can also invite whomever they want to be part of those meetings. I think that that's a really important part of that law, is that families have the support that they need and have the right to bring whom they want. And then the review cycle for an IFSP is every 6 months. We write those individualized family service plans for a full year, but every 6 months we're looking, are these the right outcomes? Do we have the right services in place for the child to be and family to be successful in meeting those outcomes? And then with an IEP, the review cycle is annually. So that team is sitting down and talking about the success of that child's educational year, and should there be anything additional in place to support that child in that educational setting. Hopefully that answered your question, Kim. All right, can we go back a couple slides, Jessica? If you'll go back to the big slide I was on, I'm just curious, I'm going to pause here, and if there are any comments or questions regarding this slide, I think I'm just trying to judge whether or not it's too busy, if the right information is here, again, kind of piloting it here in this space. Laura?
I was wondering, I like the pie chart, but I was also wondering, the other services, is that something that's driven by provider capacity? Are we short with some of those services, or do we not have providers for that, or is it because of need?
I think that it is all of those things. So I think that there is definitely a shortage of providers who provide those services. That most of the other services that are delivered are nutrition services. We have a number of registered dietitians that provide those services. We do not have we have very few social workers. We do have psychologists that provide evaluation and ongoing support services. But I think one of the barriers is families don't always know that those are available or when they might need them. And we've been trying to provide our service coordinators with more professional development around when to offer those additional services to families. But then there's also that capacity issue at the same time. So, but the capacity issue can also be a result of not getting the referrals to those other services. One thing that our team has been looking at is social work in particular. And currently, in order to be an enrolled first step social worker, you have to be a licensed clinical social worker. That puts up barriers to doing that work. And potentially the rate at which we're paying for that does not support the level of schooling and commitment to be that licensed clinical social worker. So we're taking a look at those services, and are there additional barriers that we could kind of remove so families have more access to a wider variety of social work providers.
Christina, this is Jim. You asked for some summary of what we think of the slide. It's got great information, and whoever put it together did a really nice job with the professional development of this slide is great. It's an awful lot. And for me, I'm looking at my computer and I can see it all. But if this were on a big screen, I don't think I'd be able to see very much of it. And
okay,
that's not just because I'm old. That contributes to it, my eyesight. But overall, it's obviously a lot of really great information. A couple other things is that the thing on the top right, I think it's trying to convey, hey, look, we're actually increasing the number. And I understand that the little cliff at the end is just because it's only a portion of this fiscal year, but it kind of looks like, oh, we just decided to stop doing services,
Okay.
Yeah, you could even put like a dotted line, like this is our projected, or something.
Okay.
And then the last thing on the exit data, it kind of looks to me like that 2007-05 or what 706, the purple, it almost looks like, oh, here are the people who just dropped out. I don't think that's the the fact, and so I don't know, just looking at that alone, I looked at that and I thought, gosh, only 277 were successful and 2,000 weren't. And I don't think that's what is trying to be conveyed on the slide.
Thank you for that feedback.
Anyway, I mean, it's a terrific slide. I put slides together a lot. I don't do this good a job ever. So, but it may just be too much.
Okay.
This is Kate Barrow, and I like the information presented. I agree with Jim. It's very professionally done. It is busy, and I think if I were outside of this world that I'm very familiar with, I would also maybe misinterpret the meaning of exit data. It might be good to have kind of if this is like an infographic or a one-page handout, that something that corresponds with these are children who have met their goals or who are moving on to the next phase of support system, something that kind of brings the jargon into layperson's language, like everyday people language. I didn't even notice the cliff piece, but when Jim said that, I was like, oh, that does kind of look like everybody's going to fall off the cliff, and that's a very uncomfortable image. Sorry.
No, it's okay.
The number of children referred, the only thing I would say about this icon is it's using the cell phone icon with the little waves, I guess. I would not have associated that icon with a referral. I'm not sure how you would do that. That's it looks really good. It's a very clean graphic. I just wonder too if there's a way to break down some of this information as like success measurements, or this is what services delivered means for children. I think about community living and being with the whole family, things like that. That's kind of where.
Okay. Thank you all for your feedback. I appreciate it. Again, you're getting the first view of this slide. The governor's report will be a static, obviously, report that he will receive. Now, but his report does not have exit data on it, has family survey data on it. But that hasn't been something that we've reported in the past to this advisory board or, the QFR. So we thought the exit data might be important here too, but I can understand your perspective and how to tell that story a little differently. So thank you very much for your feedback. Lexi.
I liked what the last person said. I think it was Kate, about the and the child in the basically context of like their whole family. I wonder if it'd be cool to use like the charting in the life course image and description about the person in the context of their family and community. I don't know if a lot or all of the first steps employees are life course ambassadors, but I think that'd be really cool to use because I don't know, I'm so passionate about charting the life course and I think it really works. So implementing charting the life course into the slide and into just a lot of what you do, I think would be a fantastic thing.
Awesome. Great. Thank you, Lexi. Appreciate the feedback. All right, we'll move on because I know that Holly has a lot to get to today. I wanted to provide you with just a funding update regarding first steps and sustainability through SFY 2025 or state fiscal year 2025. We do utilize a wide variety of funding sources to help us implement the First Steps program and sustain it. And so this is just a depiction of what all those sources are, what is mostly used to support the program. And as you can see, Medicaid, we do provide the majority of our services are provided to infants, toddlers, and families who are enrolled and receive Medicaid services. So it did make up almost 37% of our budget last year. And this is just to fund the services of our program. It does not include service coordination. Service coordination is supported by those federal Part C dollars. So the remaining funds go to support that. And we spent roughly 24 million on service coordination last year. As I mentioned, that is the only required service that every single child and family receive. And we do that through contracts with entities who hold those contracts for our system's point of entry. One thing, we'll move to the next slide, and that is our private insurance recoupment. To ensure sustainability of First Steps, we needed to diversify that funding and really ask for private insurance to help cover the cost of these services. We have been pretty much working on improving this private insurance recoupment process over the last 4 to 5 years. Before moving to our current vendor who helps us do this, we were recouping around $3 million annually. And as you can see, last fiscal year, we were at $18.5 million in private insurance recoupment. So I want to give kudos to our provider agencies who have really helped in this space, our interagency coordinating council who helped advise and assist in this space. And our vendor public consulting group has really helped us in making sure that our claims to private insurance are using correct and current coding, and that we're following up with our service coordinators to make sure that families' insurance is being updated annually. Families understand how their insurance works, and that we get consent to bill their insurance for the services that we deliver. Next slide, please. Oh, Lexi, you have, or were you going to say something? I'm sorry.
Alt mute. Currently unmuted. Alt plus A.
If you didn't have your hand up, I just thought you turned yellow, so I wasn't sure if you were going to say something. I'm sorry.
Oh, I don't know. I touched my keyboard, but maybe that's why it turned yellow, but I wasn't gonna say
Okay.
anything. Thank
No
you.
worries. Sorry to put you on the
Christina,
spot.
Kate had a question about what is the match requirement for the federal to, what is the match requirement for the state to federal dollar?
There is no federal match for our federal grant that we receive from the U.S. Department of Education. We have to turn in an application every May, and then the federal government is required to funnel monies to our Part C programs based on those applications and the budgets that we've put together. The allocations are based on birth rate in each state. So it does vary from year to year. On the next slide, I'll show you what we did receive this year for our federal grant. Again, we did shift how we're using those funds. The majority of those funds are going to support service coordination in Indiana. Prior to that, we were using monies to help support the services. But as you can see, with private insurance paying for a lot of those services, and then Medicaid also paying for those services based on health insurance, we have shifted those funds to help support service coordination. So Jessica, if you'll move to the next slide, please. And we'll skip this one because we already went over it. So some program updates. We did get our federal determination every year in June, after we've turned in our annual performance report. The Office of Special Education Programs reviews that, as well as all of our requirements. We did receive the federal determination of needs assistance. That means that we did not demonstrate full compliance in all of the compliance indicators and results indicators in our annual performance report. We're receiving technical assistance, and we're going to kind of talk about the federal monitoring that occurred last August. in 2024 and what we're doing to kind of improve in that space. And are hopeful that once we've met all of those requirements, we'll be at meets requirements. The federal grant that we did receive in July was $11,244,927, which was an increase of just over $300,000. Kate.
Thank you so much for answering that question. That helps a lot. I probably missed this in a previous meeting, but could you talk just briefly, because I know Holly has a lot of information to share. Can you talk about caregiver coaching, what that looks like, or what the intent is for families? It sounds really interesting.
Sure. So we did have an RFP out for caregiver coaching. It is something that we've been working on since 2021, using the model family guided routines based intervention. So we're working with families to identify what their child's needs and strengths are, as well as where they kind of struggle in their daily routines, or where those natural places are in those daily routines to work on those areas that we've identified as needs, to help their child learn and grow. So it's more natural, so they can start to embed those therapeutic strategies into what is happening every day in their routine. So if it's not setting up an obstacle course, that probably shouldn't be the routine that we're working on, right? So we know children bathe, they get dressed, they have their diapers changed, they get in and out of the car, they eat meals with their families. Many families play outside together and or go to the park, or we know that families grocery shop with their young children, and being able to get through those routines is really important. And so we're working with our professionals to help families identify those routines, as well as identify where those therapies can happen more naturally, because we understand when families are carrying those over day to day and it's embedded in their routine, those skills get practiced. And that's what will help that child grow and learn, not just our therapists coming into their home quarterly, bi-monthly, or weekly. So really wanting them to take ownership over those therapies and work with their children ongoing. Does that help answer that, Kate?
I think that sounds amazing, and I would love to hear more about it after this meeting and see if that's something that would really resonate with our family networks that the council are funding. I think they would really like to hear about that.
Great, thanks.
Thank you.
All right, I'll speed this up because I know that Holly needs to get to a lot of things today. We did go through federal monitoring last August in 2024. We had an on-site with the Office of Special Education Programs. We finally received that monitoring letter in July, at the end of July. So if we go to the next slide. I've provided you a QR code if you'd like some light reading and what our findings were and what OSEP had to say about our early intervention system. You're more than welcome to access that. It is publicly posted, at least it was earlier this last week. I don't know that that has been taken down, but if you do not see it and you would like to have a copy of it, I'd be happy to forward that to you. We were issued 11 findings. There were 5 in our monitoring and improvement section of our system and 6 in dispute resolution. We are the only state to date to not receive a finding in fiscal. So I'm going to tout that as a huge win, and I'm super proud of my team and how much we understand about the fiscal health of our system, how the federal laws apply to the use of funds, and we were able to demonstrate that last August. We did receive some feedback in ways that we could still strengthen and improve that area, and we are putting those into place. But the the biggest thing is we are complying. There are just always ways that you can be better, right? And so there were some recommendations that we will be addressing, most of them around helping families understand family cost participation, and having a stronger consent to bill insurance and helping them understand their insurance and those kinds of things. So our new family engagement manager, Jamie Lisense Spears, is also helping us with that as well. We are working on updating all of our policies and procedures around monitoring, around due process, and helping families understand their rights. We are expanding what we're monitoring. So we will be monitoring our provider agencies starting in November. And we've identified a number of things that we'll be looking at, which include timely start of services. So we are federally required to start IFSP services no later than 30 days from the date that family signs their individualized family service plan. So we'll be monitoring that. We'll be looking at agency referral processes, internal processes for how they communicate with their systems point of entry and assign providers to those IFSPs and then get them into those homes. So all of that's coordinated. We're also looking at their child outcome summaries that they're required to complete for every child receiving services for 6 months or longer. We have to have that data in order to report child outcomes, which arguably is the most important thing that we can report in early intervention, is the efficacy of the work that we do and how that's translating into better outcomes for children's development. So those things are evolving. We do have to issue annual determinations to our local programs, which includes our systems point of entry. So just like we receive needs assistance, we have developed a rubric to provide that same type of determination to those systems point of entry, and we implemented that in June. Pleased to report that most everyone received meets requirements. I think there were 2 that needed assistance, and they've already completed their corrective action plans and are well on their way to meeting requirements for next year. And then we do have to update our procedural safeguards and dispute resolution procedures to align with the federal law. So we're working on that, and we're having them reviewed by our federal TA center that is all about dispute resolution and family rights. And so more to come on that as we get those completed and approved by someone at the federal government. All right, I think Jessica, oh, and then I was asked to bring a question, but I don't know if there's time for this. So if we want to wait until the end.
There is time, Christina. You're good.
Oh,
yeah.
Okay, good.
I think I put, what time did I look? 10. Yeah, we've about 10 minutes. So yeah, you're good.
Okay, great. So here's the question that I'm bringing to you all. Is what opportunities do you see for a deeper collaboration between First Steps and other DDRS programs to support children with developmental delays and disabilities beyond age 3? And there's Lexi.
All done. Audio now unmuted. All Y.
So I'm also on the INAPSI board. And in our last transition committee meeting, we were talking a little bit about how to engage better with families. And the conversation kind of started with more like families closer to transition from high school to post-secondary work or education. But I brought up a point that I think it would be helpful to even give families kind of by age group early steps to work on vocational skills, because you can start working on vocational skills with littles, like really little kids. So we were talking about possibly reaching out to family to family and First Steps and just different entities like that, and finding out what people have, if they have what the agent provider agencies or whatever has and what they need from us about teaching families to work on those vocational skills starting in early childhood to build success moving towards transition.
We'd love to be part of that work.
Okay, thanks. I'll talk to NAPSI about it and we'll try to get in touch with you.
Wonderful. Kate?
I'm just going to go back to families because we are doing the family network project right now. Something you said earlier on about the transition from an ISFP to an IEP. It goes, I know it's the home environment, least restrictive environment for first steps and early interventions, and then the transition to the school environment. And families are involved in IEP development, etc. But I do think that there is a tiny bit of a gap in how we support the family in that transition period. Maybe doing a warm handoff or some kind of some continuation of home supports. I loved the coaching idea. I feel like that is something that could grow into that transition phase of how can I help coach you through what you need to know from moving through early interventions to an IEP system. I think that's families kind of get lost. They feel a little bit like they're on their own once they get into an IEP environment, and they're really looking at those services and education rather than services directly in the home.
Thank you for that.
So therefore, I say, how are we supposed to know? And we had permission from. You know what they need to say?
Anyone else?
You need to go to the person, or to the company they gave it. They're the ones that are going to choose them. Well, they may have.
Okay.
I don't know.
Jessica, I think that concludes my presentation. Thank you, everyone. I appreciate the time and the audience, the feedback. And we'll be back giving you another update, I think, maybe in
2026, Christina. Yeah.
So
yeah, I know. I'm trying to remember. Maybe even
I'll be able to report on how that agency monitoring went, what that kind of preliminary data looks like, as well as any other national updates as well. Thank you.
Thanks, Christina. If you guys think of anything too, you know how to reach out to us too if something comes to mind that Christina posed, and obviously feel free to reach out. All right, I am going to turn it over to Holly, and then we will have a couple things, Holly, and then I'll kind of, I'm gonna have to take a break after 3 hours, but so I'll let you know. We did build in just a quick break if anyone needs, and obviously you guys can step away if you need to, but I'll just run the slides and try to follow your lead.
Thanks, Jess, and thanks, Christina. Well, good morning, everyone. I think it's still morning. It is still morning, so good morning. Glad to be with you today. I've got a list of things to talk about today. I'm going to provide an update on the waiver amendments, an update on our self-direction model that is coming our way at the end of December. I'm going to talk about sustainability strategies, provide an update about case management, provide some information about some engagements around waiver reset. Many of you are already aware of that. Talk a little bit about waiver waitlists, and then Jess will provide some information on the home and community, and I see a typo, apologies, support professional training. Next slide. So as you all know, we have amendments for all 4 of our waivers: the family support, the community integration rehabilitation, health and wellness, and traumatic brain injury waivers that we submitted amendments for. We also submitted amendments for the Indiana Pathways for Aging waivers, but today I'm going to stick to those waivers primarily that BEADS operates and administers. So we had our public comment period that ended August 8th. As we've discussed, or perhaps you've heard, we had a lot of public comment during that period. We received a lot of feedback a lot of valuable feedback. And some of the things that we received feedback about was some swapping of services, and the picking of clinical or therapeutic services over other professional services that was really more out of a preference, as opposed to that choosing of service being based on relevant assessed need. So that was helpful for us to know that. It clearly or made clear for us that there is a need to provide some additional guidance around service definitions, potentially some modifications of service definitions, to be sure that we are conveying to teams and providers of services what the expectations are and the intent of those services. So we certainly acknowledge our role in any misalignment there. So we, again, got a lot of public comment. We reviewed all of it, took all of it into consideration. We did make some modifications to clarify the documentation of services as a result of the public comment we received. We were working to align documentation requirements across services, and it just created additional confusion. So, and potentially a lack of clarity. So we went back to some different or the previous documentation requirements on some of those services, and are continuing to look at those for future amendments. But again, the changes we proposed to create more alignment actually created more confusion. So we don't want that. We are in the amendments that have been submitted and are currently under CMS review. We are moving forward with the service-related proposed changes for the effective at the end of December, related to the service limits for recreational therapy and music therapy, as well as the reconfiguration of the behavior support services.
Hey, Holly, can I ask a quick question, please?
Sure.
Yeah. So, first of all, I really do appreciate you guys going back and doing the documentation stuff, because as I pointed out a couple months ago, that was really one of the, I think it was inadvertent, but one of the more problematic. So I really appreciate you all going back and making those changes.
Thank you.
One thing that I've been asked a lot of questions about, and it's pretty clear for behavior support, that the new service limit of 12 is an average of 12, so it's a bucket of 144. I mean, it says that very explicitly in the waiver amendment. It doesn't say that about the other therapies. It just has the monthly cap. So is that what the intent was a hard monthly cap for those?
That is the way we are going with the music therapy and the rec therapy, is the monthly cap.
Okay.
Yes.
I just wanted clarification, because
Sure.
a lot of people have asked me, including
Sure.
so anyway, thank you very much for that clarification.
Yes. All right. Thank you, Jim. Appreciate the questions and the clarifications. Some additional changes we're moving forward with are the implementation of the new comprehensive tools to assess the ICF IID level of care. This impacts individuals applying for services for people with IDD at BEADS. That's the family support waiver, the community integration habilitation waiver, and also those individuals seeking supervised group living. All three of those require that ICF ID level of care. So as we have talked about before, we are utilizing Inter-I suite of tools to complete these assessments. The Inter-I early years, which is 0 to 3, the Inter-I CHIME DD, which the CHIME stands for Child and Youth Mental Health and Developmental Disability, that assessment, and then the Inter-I Intellectual Disability. And I see we have a question. Yes, Kim.
I've just seen on some parent chat forums some concern about the inter-eye, I think, because it's completely over the phone. Is that true?
No, no, the inter-eye can be done in person or by phone, but I will tell you with the ICFID level of care, the intent is that those assessments will be in person.
Okay, that's
Yeah.
good. There was just some chatter about that. So
Sure.
I had never heard it said how it was implemented. So.
Yeah, and that, Kim, that may be because currently the nursing facility level of care, which also uses those inter-eye suite of tools, it uses the early years, the home care tool, and the PEDS home care tool. Many of those are done by phone or virtually, and can be done in person if requested. But that may be where that's coming from. But with the ICFID, those will be in person.
Okay, thanks.
No, that's a good question. The other thing I want to clarify with the ICFID level of care assessments, the initial level of care will continue to be done by BEAD staff. So when someone essentially walks in our door, whether they submit an online application or come to our office or send in a paper application, that initial level of care assessment will continue to be done by state staff. The annual levels of care for individuals already receiving services through the family support and the community integration habilitation waiver will be completed by the case managers as it is today. Any potential denial, as it is today, would come to state staff before that denial is finalized. Next slide. Some of the other changes that we are moving forward with, again, these are pending CMS approval. These amendments are at CMS and it is, all of this is pending their approval, but we intend to move forward with adding the benefits counseling service across all 4 of the BEADS waivers, which we are very excited about. It's a new opportunity for everyone we support in HCBS, but even opens up some additional doors for people in the health and wellness and traumatic brain injury waivers that traditionally have not had a full array of employment services as we have had on the FS and CIH. We're also adding the extended employment services to the health and wellness waiver. Again, that's never been offered before, so we're excited to add that. Yes, Lexi.
All done. Audio now in mute.
I have a question about the ICFIDD level of care.
Sure.
So you might get to this later when we talk more in detail about waiver reset, but from what I understand, all the BEADS waivers kind of combining into a high, medium, and low support need kind of tier of waivers. I guess the question I have, especially for people who would probably meet nursing level facility care and IDD level of care like I do, how is it going to be decided which tool is going to be used for somebody who meets both?
Yeah, Lexi, that's that. Oh, I'm sorry. I didn't mean to cut you off. Go ahead.
Oh, I was about to say, and could be on like either waiver, health and wellness, or DD right now, how it stands today.
Great question. So we will talk some more about that as we get to the waiver reset, but just because you asked it now, I want to address it somewhat. So the waivers we intend to move forward with or stand up in waiver reset, and we'll talk a little bit more about that. We'll have a new service array, and also will be cross disability. So the idea is that you wouldn't have to necessarily choose a particular waiver, but that you would choose your services. Either level of care could deem you eligible for that service array, whereas today people have to choose, right? If they meet both level of cares, they're choosing which waiver. So we'll talk a little bit more about it when we get to waiver reset, Lexi. So if I didn't answer your question fully, if you can hang on for a little bit, we'll get to that. Okay.
All done. Audio now unmuted.
You answered it really well. Thank you,
Oh,
Holly. You
all
gave
right.
you gave me kind of what I was looking for, and I'm
Okay.
looking forward to hear more later. So
Great. Yes, Laura.
First of all, very, very, very excited about the benefits counseling service coming on. I think it'll be a huge help. But I also wondered, I guess people will have to sign up as a provider for this. How are we looking at capacity for that as oncoming? Because I can see that it'll be used quite a bit in the future.
Yeah, we think that it will be utilized. I think it'll take us a while to ramp up for people interested in it. But we will be issuing something very soon about providers and how to enroll in that. I don't have all the details with me at the moment, but that is something we will be announcing very soon because we do need to get those providers on board. Yeah, but we are very excited. Again, just so everyone, as a little reminder, this is a service we've added so that people can, not to be too cliche, but kind of kick the tires, right, of what it might mean for them if they went to work in a competitive job. So we really think it will be a great educational tool for individuals and families and really lead to people having more opportunities to engage in employment. Lexi.
All done. Audio now unmuted.
I just want to second what Laura says. It's really exciting. After kind of having conversations with people from DDRS about it and people from like VR and INAPSI, what I like about it is it's kind of like a tiered system. Like vocational rehab is like involved in that initial, like you're getting a job. We're going to provide you with a BIN officer to help you realize like how it's going to affect your benefits. And then WIPA is kind of like you have to be like really looking or, planning on or starting a job to get, because WIPA is so overwhelmed. But what I like about having it on the waivers, and I didn't at first because I didn't get it. I'm like, well, you could already get that from VR or WIPA. But what I like about it is it gives individuals opportunity to explore what employment would mean for their benefits, even if they're not necessarily planning on seeking employment immediately, but just kind of want that initial, like, this is what it looks like for you. And it might look different than what you think, because a lot of people think if I work, I lose all my benefits. So
That's it exactly, Lexi. Couldn't have said it better myself. Great job. Yeah, we are very excited about that.
Hey, Ollie, I got a question.
Sure, Tom.
So have you had communications with those at CMS who are reviewing the amendment since the shutdown? And if not, at what point, as the federal shutdown kind of moves forward, do you think it will alter the effective date of the waiver amendments?
Tom, that is a great question. We have had communications with CMS, FSSA has, and we do not anticipate that the staff that review these amendments are still in place at CMS and are continuing their review. So we do not anticipate any delays at this time.
Good. Thanks, Holly.
Yeah. No, it's a great question, Tom. And it was something all of us have been thinking about, I'm sure. Okay, the other item we are moving forward with is discontinuing, back one slide, please, Jess, is discontinuing enrollment in the facility-based pre-vocational service. This is, as you will recall, as part of our employment transformation plan. It's something we've been planning for quite some time, and we do intend to move forward with that as well. And that obviously applies to the family support and the CIH waivers. All right. I don't see any other hands up, so I'm going to jump to the next topic. First, we have talked about a lot of the changes in previous meetings or items in the amendments in previous meetings. We had not really talked much about the self-direction model. This is an area of particular passion for a lot of us who have worked with individuals and families with intellectual developmental disabilities for years who have asked for the opportunity to self-direct some of their services. So when these amendments CMS has completed their review of these amendments, and we received the approval we anticipate, this is a huge win particularly for individuals with intellectual and developmental disabilities and their families, because again, they have asked for this for many, many, many years, and we're finally to a place where we can implement some self-directed services. So just from a general perspective, those self-directed services really allow for more control and flexibility over the support individuals receive. So there will be, they will have additional control over how the funds that are allocated to them, regardless of self-direction, right? The funds that are allocated to them for use in meeting their specific assessed needs, they'll have more control over how they can use those allocated funds. And we'll talk a little bit about that. There's flexibility of services within the established service definitions. And then there's an emphasis on individual empowerment. It really does put puts the individual in the driver's seat in a lot of ways, and in the driver's seat within the framework of HCBS and how our waivers and service definitions are written. Next slide. Some of the core values of self-direction are listed here, but the dignity, respect, and rights. So it really is, as I said, the person being the driver, the person being in charge of, who's providing their supports, giving them that control back. It also is in self-direction, it is an dignity of risk is big. Individuals that decide they want to self-direct, and we'll talk some more about that. It is a huge change for an individual if they choose to self-direct their services. It's not for everyone. A lot of people will just opt not to pursue that, and that's okay. But it is, a cornerstone of that is that dignity, respect, and rights with the individual. Again, being in charge of the who provides those supports or those various services. The choice and control with individuals making their own decisions. Self-direction can really be empowering for individuals when they are directing their services. And then autonomy and interdependence. Individuals choose how much help they want within the available resources. So while this individuals choosing how much help they want within available resources also applies outside of self-direction, it is also very important in self-direction that individuals and their teams, their support teams, understand they can choose not to receive as much support as maybe they are today, or as much as their team thinks that they should. Again, that's the same as traditional services, but self-direction certainly, I think, highlights that autonomy for individuals. Next slide. So this slide should look familiar because we've shared this before. These are the services that individuals can choose to self-direct. For the family support waiver, it's participant assistance and care, or PAC, respite, and workplace assistance. For the community integration habilitation waiver, it's the hourly residential have-and support, respite, and then workplace assistance. The health and wellness and traumatic brain injury waivers, as well as the pathways for aging waiver, the services that will be able to be self-directed at the end of on 12/31 is attendant care, respite, which is the same across all of our waivers, and then the home and community assistance, which is really what we used to call homemaker services. So individuals will have the option to self-direct any of these services once those amendments are approved by CMS. From a national perspective, when self-direction is an option in HCBS, what is seen as about 10% of people choose to self-direct. Again, it is a lot to self-direct, and I don't say that to discourage it. I just mean it is a lot. It is a lot of work compared, but for the individual, compared to the more traditional model of service delivery. But it is a very good option for a lot of people who want to try it. We anticipate a 2% increase year over year in the number of people who choose to self-direct their services. Yes, Laura.
Sorry. The question I had is if there people are doing the self-direct, which I'm glad that they have that choice to do that, but if an STBR and LTBR is needed for somebody who's doing a self-direct, will there be additional steps to that or information that is needed when those are submitted? And what does that look like?
Yeah, that's a great question, Lauren. We'll speak to that in a future slide. I think a lot of it depends on the reason for the STBR, for example. So a big piece of self-direction is individuals with support being able to manage their allocated funds for those self-directed services. That is a requirement. So individuals who essentially overspend their their allocation or their funding allocated funds because of lots of different reasons, but they overspend, and we can talk through some of that here shortly. The STBR will be may not be an option for those individuals. So it's really key that individuals that choose to self-direct understand from the beginning that these are the funds you have based on your assessed need, and these are the funds available for this particular service. For example, the PAC. I'm just using that as an example. These are the funds you have for PAC minus 10%, which we'll talk about that as well. And that has to last the plan year. So it's a lot of planning, a lot of coordination to self-direct those services. I think I saw another hand up, but maybe not. Okay. So Laura, I hope I answered that question for you. Okay. Oh, go back one more, Jess. A couple other things that I just want to mention while we're sitting on this slide is, we currently have some self-directed services on the health and wellness and pathways waivers today. Those individuals self-directing their services will be incorporated into the updated model on 12/31. This new model that we are planning to implement gives individuals who are self-directing these services budget authority. So we'll talk through a little bit about what that means, but that again gives them more control over how they utilize those allocated funds. And I mentioned that those allocated funds for those services are 10% less than the allocated funds in traditional services. The reasons for that are one, the state has to pay a financial management service provider or vendor, and we'll talk about what their role is today as well. And because the rate for those services includes some admin costs, right, that don't exist when a person is self-directing. Okay, next slide, please. And Jess is probably trying to keep me on track with time by moving the slides. So
You're doing
Jess,
good, Holly. You're okay.
poke me as you need to. So again, self-direction, great opportunity, but want to talk a little bit about roles and responsibilities so that as our advisory committee, you all are aware of some of the basic tenets of this self-directed model. The individual in self-direction develops that person-centered plan with their case manager. The individual must understand and accept the responsibilities of self-direction. They must understand and adhere to service definitions and limitations. So even when services are being self-directed, those limitations in our waiver documents, those service definitions still apply. We cannot self-direct services to be delivered in a way outside of the waiver definition, if that makes sense. The individual will recruit, interview, hire, schedule, manage staff, and review timesheets. So that's a lot. That's a lot. And when I mentioned that 10% of people who have receive HCBS services and have the option to self-direct, my thought is that's probably why it's 10%, because that is a lot of work. Again, not discouraging it, but just noting that that is a lot of responsibility, and we want individuals to have a clear understanding when this is being discussed with them as an option about their responsibilities there, because that's very different for most than what they have today. Yes, Lexi.
So I just want to touch on for a minute the accessibility piece of it for individuals self-directing. When you talk about reviewing timesheets, I want to kind of confirm that the staff will be clocking in and out via EVV, and that will be accessible for people who are blind or have low vision to review the timesheets, as well as just any other format that any materials need to be in. I think we really need to have a focus on accessibility, because I know that, especially on health and wellness, blindness and low vision is kind of one of the pieces of it that, at least it was on the A&D waiver, that kind of qualifies individuals. So
Lexi, that's great feedback. Thank you. Thank you. Yes. And then I thought I saw another hand up. But
yeah, it was me actually, Lexi.
Oh, okay.
Asked the question. I was going to ask if EVP was going to apply, because some of the very services like PAC and respite and you know, RHS hourly are the EVV. That's basically the EVV program. So is EVV going to be part of it if it's on the on this self-directed?
Yes.
Okay.
Yeah. Great questions. The other items or responsibilities for the individual is managing and directing their services and supports, right? Working within program guidelines, and then communicating and asking for help or assistance when needed. So the employee or the HCSP, the Home and Community Support Professional, still getting used to that new acronym, really must be someone who embraces the self-direction model of choice and control. They have to recognize and understand and respect that the individual they're supporting is actually their employer. They still have to meet the qualification and training requirements of an HCSP. They may not be the LRI of the individual, which is, again, parent of a minor child or a spouse. And they must provide support in accordance with the waiver service definitions and the schedule set by the employer, which, again, is the individual. Next slide. I want to talk about case manager's role in self-direction, as well as a self-direction representative, but we'll start with the case manager. So case managers will have a key role in self-direction. And when, again, I'm just going to put this out there, the self-direction will apply as we discussed in an earlier slide for the Pathways for Aging waiver, but our discussion today, and as I talk about roles and responsibilities, is really going to be focused on the 4 waivers that BEADS administered. So I'm going to talk about case manager's role, right? So the case manager's role is going to be very critical. They will have an integral part in the success of individuals in self-directing their services. They will discuss the option to self-direct services with the individuals and provide unbiased information about the self-direction model. We want that information to be direct and unbiased, right? It is the individual's decision or their legal rep's decision, not the case managers. We want the case managers, or expect the case managers, to support the individual's ability to make an informed choice, create the service plan in accordance with the rules of the waiver and self-directed services, and then link the individual to the financial management services provider, or the FMS provider, because we all need another acronym in our lives, and then monitoring the individual's ongoing needs and service plan. So case managers will be sharing information about self-direction at intake, at renewal, or upon request. We have a self-direction exploration tool that case managers will utilize with individuals. And they will then assist in, if a person decides to self-direct, the person-centered or the PCISP, they'll help convert the budget to hours, build emergency backup plans, and so on. Yes, Laura.
In order to, I guess, monitor the hours and utilization, right now, case managers, they look to the quarterly reports and to the paid claims, and there's quite a lag time with both of those.
Sure.
Is there going to be anything that kind of tightens that up so that we can do a good job of making sure that people aren't overutilizing and we can support them in that way?
Sure. And claims won't be the way to do it. You're exactly right,
No.
right? Because providers have time to file claims. And yeah, so there will be, again, the individual will approve timesheets, but there will also be the FMS vendor that will provide data and have data available on hours. And we'll get to their responsibilities here in just a minute, Laura. But yes, you're right. There needs to be more, there will be more real-time data than what you see today. As a case manager.
Thank you.
Great question. Yes, Lexi.
I'm sorry, I'm full of questions today.
That's okay. That's what we're here for. No
Thank
problem.
you. So, from what I'm understanding, the case manager will also play the role as the support broker. So we do not have a specific support broker. Gonna kind of be the case manager, and then I have another question after that.
That is correct. The case manager will be filling that role. There is not a support broker in this model at this time.
And then my second question is, and you might be getting to this in a little bit, but I know the contract with PPL was not renewed. What's the plan for a fiscal intermediary, or I think you called it an FMS?
Yeah, no, same thing, Lexi. Different words, same entity. Yes, we have secured a new vendor that will take the reins essentially on December 31st. So I'm not ready to give the name quite yet, but we will have a different vendor on 12/31, a different FMS or fiscal intermediary. Great question. Sean?
Maybe I missed it, or maybe you talked about it, but who determines someone to be able to self-direct?
That is a great question. So individuals can choose to self-direct. The case managers will have toolkits to walk through that process with the individuals or the individual individuals on their caseloads to help the individual or their support team consider, is this something that's going to work for this individual, and do they really want to do that? Again, Sean, it's about 10% nationwide of people that actually self-direct, and I think some of that is individuals decide that's not something that either they feel like they're positioned well to do because it's a lot of monitoring, or they just don't feel like they have the time, right, to do that self-direction and to do that recruitment and interviewing and hiring and firing. And, that's all pretty intense stuff. Great questions. The other role within self-direction can be a representative. Now, this is not a requirement, but a representative may be someone that an individual chooses just to help support them. It may be family, it might be a friend. It would just help support that person. So I always think of when at Beads, when we do interviews for people who want to work at Beads, we don't do them one-on-one. There's someone else sitting with us, a couple of the team members that do those interviews together. So that may be a role that a self-direction representative would fill with an individual who chooses to self-direct. Let's say they're attendant care. They may want a family member or something to sit in on an interview, or to support them through the hiring and interviewing and or the firing processes, right? The representative isn't paid. They are doing that as just a means of informal support of the individual. The representative has to have a clear understanding of self-direction model, as well as service definitions and limitations. They may attend meetings with the individual. They'll help the individual potentially manage with employer tasks. Again, hiring, training, managing the budget, other paperwork. They may receive and review copies of notices and reports sent to the individual from the FMS provider. The key with the representative is they cannot be paid staff for the individual for any waiver service. So, and that's whether it's a self-directed waiver service or a traditionally delivered waiver service. It cannot be someone paid to provide any support to the individual. So these would really be, again, if there's a representative, an informal support, family, friend, neighbor, church member, things like that. Next slide. And then the role and responsibilities of the financial management service. So this supports the regulatory and financial responsibilities of self-directing. So that's the fiscal, that's reporting, that's budgets and employment responsibilities. So this FMS vendor, and we will have one, much as we do today, we just have one. We will have one FMS vendor on December 31st. They will set the individual up as an employer, explain all the paperwork to get started, including the process of hiring workers and reporting hours worked for payment. They'll complete financial transactions based on the individual's plans. They'll file and deposit all employment tax and labor payments and forms, and then they'll track and communicate about spending or payments with the individual and their team. So this is a key role, and this is the role that the state covers the cost of, which again goes back to that 10% reduction in a budget if you choose to self-direct. Yes, Laura.
With the new training being centralized, will there be some kind of mechanism that allows us to confirm that individuals that are, I'm sorry, the new letters, but the DSPs Um,
The HCSP, gotcha.
Okay.
Yeah, I know
If-
what you mean by DSP. though.
Okay.
It's fine.
if they've gone through that successfully.
Yes, the individual, and Jess, if you want to jump in if I misspeak, but the individual will be able to produce documentation that they have done that. Yes. And should be asked for that, actually, right? Because that is a requirement.
And Holly, I would just add, the registry will be public and an individual, you can search by individual and see that they're credentialed.
Mhm. All right. Jess, are we okay or do we need to take a break?
We've got Holly just about, let's see, I'd say you've got 2 more slides to maybe just wrap it up kind of soon.
Okay.
We're a little bit, yeah.
Okay. I'm just trying to watch the time.
No, you're fine.
So also want to talk a little bit about service plan development and developing those self-directed budgets. So the team will discuss the person's needs. Again, this should not be unique to self-direction, right? Those discussions with teams should be about individuals' assessed need, regardless of whether it's self-directed or more traditionally delivered services. But the team will discuss the person's needs, and then the team and inclusive of the individual, that should go without saying, but I'm going to say it anyway, will select services with the appropriate number of hours based upon the assessed need. And then the number of hours are multiplied by the rate for a total dollar amount. Then 10% of that total is deducted from that total self-directed budget for that service. Again, that 10% is used to fund the FMS vendor, and again is built into the existing rate because of administrative overhead that doesn't exist in self-directed services. So I mentioned earlier that the self-direction model will include budget authority. What that means is the budget authority allows for individuals to select the rate of pay for their workers within what we set as the minimum and maximum wage ranges. That is one of the benefits of self-direction. It can also be, it's also something that requires very intensive planning, right? Individuals will balance the hours of service they need versus the rate they wish to pay in accordance with their budget or the funds allocated. Individuals with support, right, from their team must plan on how to best utilize their budget to get their needs met for the entirety of the service plan year. That includes considerations for things such as overtime and pay raises. So, because let's keep math simple, because Holly's not great at math. If we have $100, right, and we want to pay $10 an hour, if we're going to stay at $10 an hour for the full plan year, and never give that HCSP person a raise, then $10 an hour would work, right? If you have 100. But if you want or feel like there might be a need for overtime, that has to be considered when you're thinking about wages. And again, we'll have toolkits that can be used to help people navigate that space and address those issues. But the key is there is that responsibility of the individual to ensure that the wages they choose to pay will be balanced with the available funding for the service, for the amount of service that they need. Next slide. So termination of self-direction. So individuals may voluntarily discontinue self-direction at any time for any reason. So if an individual Jess decides she wants to self-direct her attendant care, and she's a month, 6 months into it and is like, yeah, this isn't for me, then she doesn't have to continue to do that, right? She can go to the more traditional service delivery model and stop using self-direction. It doesn't terminate services. It just changes the model of how those services are delivered. Individuals may also face involuntary termination if they are unable or unwilling to follow program rules. So if there is a service is being self-directed and there is non-compliance with the service definition, if there is individuals are exhausting their budget before their plan year is done and they're left without services, those are indications, right, that the individual should not be self-directing that service. Lapses in service delivery will be avoided whenever self-direction is terminated. Again, it is just a difference in how the service is delivered should self-direction be terminated for any reason. All right. Okay, let's stop there. And I think we have some questions. Lexi?
All done. Audio now unmuted.
So I heard you talk about, kind of not really a lapse in service delivery, but at the same time, sometimes it takes a while to get staff through a provider agency, whether it be no matter what waiver it is. Will that possibly cause a lapse in care, or will self-direction continue until somebody can pick it up, even if the person doesn't really want it to? Can you touch a little on that?
Sure, that will really be up to the individual if they want to continue self-direction until another provider is in place. We wouldn't necessarily require that. If the individual says, I don't want to do this, the team would talk through what that would look like for the individual. The other thing is, Lexi, in some of those situations, the HCSP may go to work for a provider, right? They may want to continue to support the individual and may decide they'll just go to work for a provider. Maybe not. Our self-directed services today are just a different model. So this is our first kind of step into a consistent model of self-direction. So I think our goal would be that we would not have any lapse in services at all. But as you noted, there's no guarantee, right? But the goal would be that the team would work through those issues. If the individual is, for example, having difficulty self-directing, that there's proactive conversations happening about, okay, do we need to, let's talk through transitioning back to the more traditional service delivery model, so that there's some proactive activities occurring to prevent a lapse in service. Does that help, Lexi?
All done. Audio now unmuted.
Yes, absolutely.
Okay.
Thank you.
Great question. Jim?
There are a couple questions in the chat I just wanted to alert you to. One of them is mine. So
Okay. Most HCSPs in Indiana will be paid by waiver providers for their time in the required HCSP trainings. How will that work for HCSPs who are employed by individuals who are self-directing? That is a great question, and I'm going to have to get back with you on that. I need to double check a couple things before I respond to that.
Holly, this
yes.
is Kelly. I would answer in general, and I think Heather's on as well. As it is in the current model, the individual is the employer of record. They are responsible for any training. So that would have to be considered as part of being an employer.
Thank you, Kelly.
Is there
Sorry,
Sorry.
Kate, go ahead.
I was going to say if the individual or the employer of record is responsible for providing training to the staff that they hire, are they given a framework for what training that is required, or what's?
Yes, they would still be required to follow 460 IAC and any other applicable codes for the specific waiver.
Are there plain language guides for individuals, or will there be plain language guides for individuals?
In the toolkit, Yes, in the
Okay,
toolkit.
perfect.
And again, I think, Kate, that's a great question. And Kelly, thank you for the response. I really can't stress enough that self-direction is within the framework of HCBS. So the requirements, the provider requirements, the DSP requirements or HCSP requirements, all of those remain. And there has to be training, you know, that is all required. The service definitions, all of that will exist and continue to exist, even in the world of self-direction.
Except that you're paying 10% less. So some of that overhead that would ordinarily maybe go to training isn't going to go to the self-directed. I mean, I truly,
Jim,
Yeah.
I will say the hourly rate that we currently use under a traditional model has administrative overhead as well as training factored in.
Correct.
The 10% does not touch the training
okay.
component of the rate methodology. It only covers administrative overhead that would typically go to a traditional provider.
Okay. Maybe it's just that I don't quite understand the the actual way that the self-direction will work in this case. I don't know how. I mean, is there an extra funding pool that an individual would have to provide that training, or would that, I mean, this is kind of where
No,
I'm stuck on it. So I don't
no,
know.
they're the allocated dollars available to someone on self-direction is the same as someone not self-directing minus the 10%.
Okay.
There isn't a separate pool of funding for other items or other things like training.
Yeah,
Sorry, Kelly, were you going to say something?
Well, I don't know if I'll muddy the waters or if I will make things clear.
I'm sorry, Kelly.
No, this is my goal to make it clear, so I hope that it is. So, and I think the current rate, and I may be off by a few cents for RHS or attendant care, it's about $35 an hour. Am I pretty close? So if that would be, if someone is choosing to self-direct RHS, that's the factor, the $35 an hour minus the 10%, which was what, $350? So that would come off. So then it would be the $31.50 per hour. What remains in that has to cover wages, benefits. By the way, they're the employer of record. They have to have workers' comp. Those things, that's required. And then that original rate of $35 an hour has so much for an hourly wage, so much for benefits, so much for training, so much for mileage, and then an additional layer for the administrative overhead. So the $31.50 that's left and what I just put forth would still have within that an hourly rate, benefits, mileage, and training, and those things. It then would be up to the employer of record, in this case, the individual. As Holly said, what are you going to pay on the hour? Now you got to factor in, you still got to pay, right? FICA taxes, Social Security, required unemployment. That FMS is going to be taking those payroll taxes out. So if I'm getting $31.50 an hour, I can't pay out $31.50 in an hourly wage, right? Or I could choose, maybe I've got enough for 10 hours at $31.50. Maybe I only want 5 hours because I think 5 hours of high quality, and the team and I talked about it, get me to where I want to go. So that's factored into the process. But any training that's required is the responsibility of the employer, but it's covered in that rate. The individual would have discretion as to how to use that. Do I want 10 hours at $25 an hour for someone, or do I want 7 hours at whatever? That's some of the discretion, but they still have to pay the FICA taxes. They still have to pay for training, those types of things. Benefits, as it is with any other employer, they decide. Am I offering benefits? Am I not? So I don't know if that helped.
Thanks, Kelly. That does help.
Thanks.
So I'm looking at the time. I think if we can take Lexi's question, and then I think we probably need to break, Jess. But Lexi?
Olga, audio now.
So I may be wrong here, but this seems like a bigger dig into someone's budget than just using a service provider, which makes me realize why nationally this is only used at 10% if we're following a similar model to other states. Especially the family supports waiver budget not being as high as a lot of times as like a CIH or a health and wellness budget.
Yeah, Lexi, so it isn't. The individuals aren't losing services at all. It is certainly something where they may decide that they're going to get less service because they want to pay a higher wage for PAC, for example, right? If they choose to self-direct PAC, they may choose to pay that HCSP more than what that HCSP would make for or be paid by a traditional provider. And because they choose to do that, they may have access to fewer hours. But it's up to them. That is their choice on how they want to do that. Some people may want to do that, right? But it is their decision. Again, it's a person's decision if they want to self-direct some of those services or not. I hope that helps. I know this is a new concept for a lot of us, so.
It definitely helps though. Thank you.
Okay.
And thank you, Kelly, for explaining a lot of it too. You guys have both been really helpful.
It's a lot of activity on the backside, and Holly, you did a great job. It doesn't, to your point, it doesn't take any more of the budget. It just allows you to use the dollars differently. So there'll be more info coming out with the guide. Heather Dane and the Beads team have really been working on that piece. So these are good questions.
Great questions. Great questions.
So Holly, we'll go ahead and table the rest of these until if we have time in the parking lot. We just don't have time, I don't think. But we're gonna take about a 10-minute break if that works. So we'll be back here about 11, I'll say 28. And so if you guys don't log off, it's just probably too much of a pain. If you want to just mute yourself and turn off your camera, we'll take a quick break and be back in about 10 minutes. Go ahead. I think we're recording, so we should be.
Sure. Okay. Thanks. Before we move on to the next topic of sustainability strategies, I do want to clarify something that I said about EVV and self-direction because I was mistaken. EVV will not be required with self-direction. It is not required today in the self-direction model that we have today and will not be required when we implement the new model. So my apologies for that. Luckily, I have a wonderful team that came in immediately and was like, hey, you misspoke there. So I just want to clarify that EVV will not be required on self-directed services. Thanks, Jess. We can move on to the next. And then we'll address other questions, as Jess said, if we have time in the parking lot. So
yeah, make sure you save your questions. I have them saved over here, but just make sure we go back to them when we're done. Okay, go ahead, Holly.
All right, thank you. So we, as this is not news to anyone here, that we are in a situation or in a space that we need to really ensure that our services, our home and community-based services are sustainable in the short term while we work towards our full waiver reset in 2027. And we'll talk some more about that soon. But we have, just as a point of information, and this may be something that Kelly has shared in the past, but want to reshare. In 2013, from 2013 to 2025, we have grown the number of individuals with intellectual and developmental disabilities that we support by over 230%. actually 236% to be exact. That's an 11% increase year over year. It probably goes without saying that our funding has not grown at that same rate. And we have to ensure that our services are sustainable in the short term and the long term. Waiver reset will help us tremendously in the long term. But in the meantime, there are some sustainability strategies, if you will, that we are undertaking to address the increase in spend on particularly the CIH waiver. We have just seen continued growth in the cost associated with the CIH waiver per individual. So some of these things I wanted to give this group a heads up on some of the actions and activities that we are engaging in now and will be continuing to engage in over the coming weeks and leading into, again, our waiver reset. We are working to ensure compliance with service definitions. Again, we learned during our public comment period that there are some issues there in some areas. So we are looking to ensure compliance with service definitions and relying to a degree on case managers for support with that. We know we need to refocus all services on inclusion and supporting individuals in building connections in the community. I always think of it as inclusion is the right path. It's the right thing to do, right? It's the right thing to strive for, to expect for individuals with disabilities, that they would be included in their communities. But that inclusion also supports sustainability, right? Building those connections in the community, building those natural and informal supports can lend itself to a sustainable system of paid supports. Ensuring the type and level of services a person is authorized to receive is based on current relevant assessed needs of the individual. You know, is the individual's needs, have they changed? And if so, their level of service may need to change. Increasing accountability, increasing consistency in case management service across all HCBS, and we'll talk a little bit more about that today. And ensure that case management is really focusing on monitoring service delivery and utilization, monitoring individuals' health and safety, assessing service outcomes, and holding support teams and providers accountable to those service definitions and to addressing the assessed need. Yes, Jim.
Yeah, so I'd like to just gently push back on the dramatic increases since 2013, because most of those have been family supports waiver, and it's wonderful that there's a very large increase in the number of people who are receiving appropriate supports, and I applaud Indiana for having put a waiver in place that allows people to have some supports. But I do think that we do need to realize, I mean, during that same exact 12-year period, there hasn't been a dramatic increase in the number of CIH slots. Granted, there is an increased spend, and I understand that. But since 2013, there's also been like a 40% increase in or 40% decrease in the value of the dollar. So not all of that is just dramatic increases in spend. I mean, increasing by 3 times. We didn't have a family supports waiver, but our CIH is pretty close to what the former IDD and autism waivers were combined. I mean, it's right around 10,000. So I'm just gently pushing back that it's not like we've hit a cliff of 230% increase in expenditures.
Yeah, Jim, I appreciate the comments. I will say we didn't have the family support waiver, but we had those oh my goodness, the SSW.
Yeah.
I can't remember what the SSW stood for now. It just fell right out of my head. But we did have that smaller, if you will, capped waiver even before the FSW. And I believe that came in around 2012, I believe. But I would have to double check
I will
that.
say, Jim, just for your point of clarification, I agree. I don't think Holly was saying there was a 235% increase in spend. We just talking about the growth and the numbers served. Obviously, we have seen an increase in spend just because of additional individuals. But to your point, I think the references to the numbers served.
Mm-hmm. Correct. And not served through any particular.
And I think Indiana ought to be applauded for that, because there are more people who are receiving services who need them, you know, and we used to have a really giant waiting list, and some of that all changed. And I know not every single problem has been solved, but I think that there's good news in what you just reported, and to me that could be sustainable too. So that's just why I was kind of gently pushing back on that.
Sure. Thank you. Okay, next slide, please. Some of the other things that we are implementing and activities that are ongoing is really looking at the use of remote supports and shared staffing as a first option. You know, those are ways that individuals can be supported in a less restrictive and more inclusive manner. So we'll be rolling out some additional guidance on, you know, the use of remote supports where appropriate, and again, really looking at utilizing that shared staffing model. For those of us who have been around for a while, the CIH allocations are really based on a shared staffing model, and the expectation that people would share that residential habilitation service. And what we've seen is some less of that sharing of services. So we really need to get back to looking at that shared staffing as a first option, and not later or as a less desirable option. Identification, coordination with community resources. Again, you know, what are those community resources that are available that individuals with disabilities should have the same access and level of access to as anyone not receiving HCBS? And how can we leverage those to support individuals? We are reviewing the processes around the short-term and long-term budget requests, and looking at timelines associated with those, and particularly in the areas of the short-term budgets, are we really, our team's really, you know, addressing the situation as short-term, and are they being creative in trying to think of ways to address a change in need, as opposed to the first step being requesting additional funding. Again, what are those informal supports available? What are those community supports available? Reviewing algo levels. This is something that we historically have not done on a regular basis, unless someone reaches out or a team reaches out and says the needs have changed, there's an increase in need. Those are the only times that those algos are looked at. So we're looking at a review of algo levels and how we can implement a process around that. Use of value-based payment models within services where we can build that in. Clarification of service definitions. Again, as I mentioned with some of the services that we received a lot of public comment about, what can we do as a state agency to better clarify expectations and service definitions? And how can we better support providers of those services? A focus on least restrictive, most inclusive settings and services. Again, you know, ensuring that we are supporting people in a way that isn't overly restrictive, that we're not essentially overserving people, to put it another way. Some clarification on reporting requirements. You know, one of the things that we have seen is reporting requirements are not always being met by providers. In fact, sometimes reports aren't being submitted at all. And we need to address that because our services should be based on outcomes. And if we're not getting reports on how those services are going and how that individual's progress is or is not taking place in a particular service, we can't know if the outcomes are being reached. So we're going to be working on some clarification around reporting requirements and then continued review of service plans or PCISPs, whatever terminology you want to use, but continued review of those to ensure that the level of service is proportionate to the assessed need. Lexi, I see you have your hand up.
All done. Audio now unmuted.
I just want to confirm the MFP is back in action.
Yes. Yes.
Okay. Thank you.
MFP is that enrollment has resumed. Yes.
We will lower your hand in 8 seconds.
All right. Thank you so much.
Thank you, Lexi. Good call out. So again, we are implementing some things, and this group will see some additional communications and things going out. We'll be working with case management very closely on a lot of these sustainability strategies because they really are the front line for us in terms of our services and supports, particularly in the area of the family support and CIH waivers. And speaking of case management, as we've discussed before, have a plan to implementation for selective contracting for case management across all the beads administered waivers. We anticipate this to be effective in July of 2026. Now that's a pretty quick timeline, and that's okay. I can give you the reasoning for that. We are looking at that full waiver reset in 2027, right? When we would sunset our current waivers and implement new waivers, those, and we'll talk a little bit more about that, but that waiver reset and the case manager's role in waiver reset as the individual and family's really primary source of information and their touchstone regarding HCBS services and supports, we have to ensure by the time we hit that full waiver reset, that we have case managers that are well informed and well trained and well positioned to support individuals and families through that waiver reset. So that is the reasoning for the timeline, at least part of the reasoning for the timeline for the selective contracting of case management in July of 2026. We have talked about it before, but we've seen some really good things from the selective contracting for case management on the FS and CIH, and believe that is the route to go to best support individuals and families moving forward. So speaking of the waiver reset, I think through our discussions today, I think the word sustainability has come up quite a bit. We know that the actions that I mentioned earlier, a few slides earlier, about some activities that we are undertaking today, particularly on the CIH waiver, and reviewing some of those algos, taking a look at plans to see if they are commensurate or if they're proportionate to the assessed need. All of those things are necessary now. But what's also necessary is that as we look at building new waivers and standing up new waivers, that those waivers are sustainable far into the future, that they are focused on inclusion, that they strengthen supports and foster independence, and that they serve as a means to connect people to existing supports already in the community and resources already in their community that is just key. And I again have one of the graphics from our Charting the Life course. Lexi, I love that you love Charting the Life course. But I think it's important that we recognize that individuals in our services really do deserve the right, or have the right and deserve the opportunities to be included in their communities, and to be able to access, again, all those community resources that other people not receiving HCBS have access to. So our new waivers will put a lot of emphasis around this, you know, and so we're excited for those new waivers. As I mentioned with Lexi's great question early on in today's meeting, the new waivers will have a new service array. Now that does, when I say new service array, that doesn't mean that services that we offer today won't be offered then, right? I'm not saying that. What I'm saying is there'll be potentially different services as well, or the services we offer today may be structured a little differently. We don't really know yet. We're still in those planning and gathering feedback stage. We will have new allocation methods with the new waivers. So what I mean by that is support budgets. I think Lexi kind of mentioned it earlier, kind of tiered support budgets for individuals based on their assessed need. Today, we have that in the CIH waiver. We have a capped family support waiver. We don't have allocation methods per se for the health and wellness and traumatic brain injury waivers, right? So we want a uniform allocation determination method across all of the BEADS administered waivers as we move to waiver reset. So that will be part of waiver reset. And as we talked about previously, and as Lexi and I were discussing earlier, those waivers will be cross disability. So we intend to continue to use the ICFID level of care and nursing facility level of care for access to those waivers, right? But that access could be via either level of care, as opposed to you have nursing facility level of care. So these are your optional services, and you have ICFID level of care, and you can choose from these services. The goal is for it to be cross disability and eligibility, or could be met with either level of care. Yes, Lexi.
Audio now unmute.
Is there a possibility of combining the level of care that we have now and creating a new level of care assessment tool?
That is not currently in the plans, Lexi. You know, we really do, you know, we utilize nursing facility level of care for things other than HCBS, as we do ICFID level of care for things other than HCBS. We've got nursing facilities that utilize that same level of care eligibility for admission to nursing homes. And then we have those supervised group livings settings that also utilize the ICFID level of care. So the plan today is to continue those two separate, two distinct levels of care. But again, either could potentially give a person access to the waivers.
Okay. Yeah, that totally makes sense. I didn't think about the other
and that's okay. No, it's a great question, Lexi. It's a great question. Next slide, please. So as we think about waiver reset, I want to share we have engaged with HSRI, Human Services Research Institute, whom you've heard of before and probably heard from. Most of you, we engaged with this same entity, HSRI, years ago when back in 2018, I believe it was, on waiver redesign. So we're fortunate to have some continuity with them, and they have a good understanding of kind of our journey to where we are today and where we need to go. They are leading engagement activities with various interest groups or stakeholder groups That has already begun. I believe many of you, the participants or the committee members, are well aware of this because they have reached out to you directly for support in scheduling and organizing some time to talk with individuals and families who are receiving services, because we want to hear from them about what HCBS means for them, what's working today, what's not working, what their vision may be for the future. Also, they have reached out to family groups or organizations, advocacy organizations, trade groups, and so on, to gather feedback. So those engagements are being scheduled and will continue to be scheduled over the next few months. I believe some are already scheduled for this month and in November. But I know there's a list of around 40 different entities, and that's kind of lumping some groups together even. So a good deal of engagement is planned so that we can get feedback for to inform the waiver reset. So if they've reached out to you at HSRI or perhaps Align Consulting, who is someone that they are also, that HSRI is working with, please get back with them because we do want to partner with you to get some engagements arranged and some feedback flow into us on people's experiences and needs. I see a quick question. What are the allocation designations? So Laura, that's all still to be determined on that question. So we do envision some tiered support budgets. But again, we're still formulating all of that and gathering feedback on that as well. Is there a plan to consult with self-advocates? Yes, Lexi, absolutely. And I believe the outreach may have occurred already, but if not, you can let me know. But I believe we've already reached out to ARC. So if that hasn't reached the self-advocates, let me know. Anything else on waiver reset? You can assume you'll be hearing more about that, right? As we continue to navigate our journey to that full reset. Okay, Lexi, that sounds good. Yeah.
I think
Jim.
all of us can appreciate the fact that you're trying to have a transparent process and working. HSRI, everybody's pretty familiar with them, and so I really, really hope that that's how it will end up. In the next year is a really transparent process because that a lot of questions get answered ahead of time, and I you can utilize the talent that you have at this particular advisory council, and I'm sure that everybody here is more than willing to provide technical support, everything like that. I know I haven't heard yet from HSRI, but I would expect to in the coming days and weeks. So thank you for the transparency.
Absolutely. Thank you. All right. Next slide. So just want to inform this group, right, that on our family support waiver, we are nearing slot capacity on that waiver. Of course, we already have a wait list for that waiver, but we are assessing our current slot utilization and what additional slots we may still have available, but just want this committee or this group to know that we are nearing slot capacity as outlined in the approved waiver. So we are going to pause the monthly invitations from the wait list while we continue our assessment of our slot status. The reserve capacity categories remain. So individuals, we will continue to process those while we're assessing our slots. But just wanted this group to know, in the interest of transparency, that we are going to pause the monthly invitations while we continue our assessment. We are also reaching or getting near our slot capacity on the CIH waiver. So again, we are, assessing what that looks like, but just wanted to share with this group that, we have some preliminary numbers that clearly indicate we're reaching slot capacity on those waivers. Yes, Lexi.
All done. Zoom escape. View button menu. Standard video renders. Use arrow key to not escape.
Am I unmuted? Because my computer just messed up.
You're unmuted. I can hear you.
Okay, thank you. My question is, I've heard that when somebody passes away, their slot remains, I guess, belonging to them until the end of what would be their waiver year. Is that still true?
Currently, that is true, Lexi. So anytime someone has occupied a slot, regardless of what waiver we're talking about, right? If they have occupied a slot for any part of that waiver year, that slot essentially remains theirs, and remains unfilled for the rest of that waiver year. We are exploring, potential options when there's, when an individual has passed away and there's no way they would come back, right? But currently that's the process, right?
Has left the meeting.
Okay, that sounds good. Because, I was thinking it's not like they're going to come back to life. It's not, I get why we do it for people who've like moved because they couldn't move back or whatever else, but it's not like they're going to come back to life, unfortunately. So,
Sure. That is one of the things that we're looking at, as we continue, in our assessment of our slots. It's a good question or a good comment, Lexi. All right. Then Jess, I think that brings us to the HCSP training curriculum. I don't know if you want to speak to that.
Already answer, Holly. I think the Lexi, you'd asked about, I'm assuming the reaching out to self-advocates. Holly, did you answer that? I'm sorry. Directly, if HSRI is.
Yes, I did answer that.
Oh, I'm sorry. I know you,
That's
I didn't,
okay.
I thought you did, but I wanted to make sure. Okay. Yes, HCBS training, and we're way ahead of schedule now, Holly. So sorry, I wasn't prepared.
No.
But the medication administration training is being finalized. So that will be added to the training platform relatively soon. We've got some experts that are taking some SMEs that are taking a look at it as well. So stay tuned for that. And then Holly, I think we had talked about this, a question regarding the settings rule and the individual rights. So I don't know specific. I was trying to remember what this question was. So if someone remembers, or if they brought it to you, I don't really remember. Do you remember, Holly?
I do. I think it was, and Sean, I don't want to speak for you, but I think when we had our prep call, it was a discussion about, is there going to be additional training on the HCBS settings rule and individual rights as part of the HCSP curriculum?
So there is training within that. There should be. So I don't know specifically, Sean, if you're asking if there's going to be additional training related to that. So just let me know if that's your question. That is touched on. Obviously, an individual's own person-centered training is not going to be covered, right, for that actual person. That's separate. But there is training within that addresses individual rights in the settings rule. We are making a couple edits to the training that aren't major. It's just some feedback that we've gotten to beef up, specifically some information around the settings rule. That won't impact the folks who have already taken it. It's nothing major. It's just some examples. We've included some additional examples, and that will be rolling out as well. So stay tuned more for that. Lexi, see your hands raised.
All done. Audio now unmuted.
I think Sean and I had both touched on that question in the planning meeting, but I think like my follow-up to that is, when I first got involved in SAI, I received the HCBS settings rule fact sheet. That's in plain language and just pretty easy to grasp, and I loved it. It
Okay.
was life-changing and perspective changing, and I think we should include that or like a module on that in the HC something training. I'm
Do you
sorry,
know,
the
Lexi, was
DSP.
that so we can create, that's a really good point. I appreciate that because there is going to be a resource. There is a resource section that we can add stuff to. So I don't know that we need to reinvent that. If if you know, was it something that Beads created or who created it?
I think Beads had created
Okay.
it. Sean, you know what fact sheet I'm talking about? Do you know who created that?
Actually, which fact sheet?
I just know I received it before doing like a HCBS like presentation for SAI, probably like 3 years ago.
You're asking me something for 3 years ago?
Yes.
Okay, well, I'm glad I cannot answer that
I
question.
think I know, Lexi, what you're talking about, which is
Yeah.
we created it. So yeah,
Yes,
that's
we
really good
did.
feedback. I think that's we can definitely keep it on our website, as well as there is a resource section so that we can definitely highlight that. And obviously if it needs to be updated, I don't know the last time it was updated, it might not, but if it needed to, we can always make that. But I appreciate that sort of feedback because that resource part of that training is not things that are necessary. I mean, there is already part of the training touches on the settings rule, but I think those resources can also be helpful, obviously, to DSP or an HCSP too. So thanks for pointing that out. We can add that.
No problem. I think Kate had dropped something in the chat too, but I think she was just seconding.
Oh yes, she was. Yes. Thanks for jogging my memory, Holly. Sorry, I feel like you probably told me that and I just couldn't remember. And I wasn't able to make that meeting. So. All right. Well, we have time now to go back. Oh, sorry, Laura. I just saw your hand.
Sorry. With all of the initiatives that are coming down the pipeline and especially the self-directed, will there be like an HRC that is, I guess, accessible for folks to be able to use? I know that BQuiz had their own HRC that sometimes providers that didn't have an HRC could put a plan into in order to ask for stuff. And I think it would be really helpful to kind of have that available again too with some of these initiatives.
Yeah, Laura, I think that's I'm off mute. Okay. I think that's a great question. The state does not have an HRC, and we haven't for, quite some time, like a number of years. So it is, providers do need to have those HRCs in place, and those could potentially be utilized, and should be utilized for those restrictive, Human Rights Committee, Kate, is HRC. We do speak in acronyms. So no, we do not have plans to develop a state HRC at this time.
Okay, let's circle back. Let me make sure, Holly. I think that's all.
Yep. I think there was. I can jump in.
Did you catch
here.
some of them?
Yeah.
I think,
so
is the self-directed under section J? I know.
Well, the self-directed it isn't a self-directed waiver. And Kate said she answered her own question.
Oh, she did.
So I think she figured that one out. So, the other question is a minor child waiver recipient able to choose self-direction in conjunction with a representative, the representative LRI not serving as the service provider HCSP? Great question. So yes, parents can decide to self-direct their child's service. However, that parent cannot be a paid caregiver. They can be a representative, right? That self-direction representative, as you noted there, Reagan, they can be the representative and support the efforts in self-direction, but they could not be paid to provide any service.
Holly, did you touch
Thank-
on Laura's question, the employee benefits?
The employee benefits, that will be, I had not
Did you
touched
already
on
answer
that
that?
yet.
I'm sorry,
I think Kelly touched on that a little
She
bit, but
did.
that will be, that'll be up
Got it.
to the
I can't
individual
keep
the
up, sorry.
employer.
Yep. Just to piggyback on that question, I know that a lot of live-in family members that provide supports, they may be able to take advantage of IRS benefits where they don't have to pay income tax. A lot of providers right now know how to do that. And I'm wondering if the fiscal intermediary will be able to accommodate that for families or individuals that employ a live-in caregiver.
That's a great question.
Is Heather still on the call, Holly? I do
I'm
know
looking to see if she is.
we've worked through that matter with the current vendor, so Heather might be able to speak to that.
Yeah, the FMS vendor would be responsible for ensuring any tax requirements or laws and putting those things in place. So the FMS vendor is very familiar and very aware of how to do all those things. And so they would be the one who would walk that family through how to do that.
Thank you.
Thanks, Heather. Kim?
Asked the question, it was similar to the minor, but if someone with significant intellectual disabilities, I can imagine this self guided thing working for people with, pretty high level abilities. But is it open? Like, is someone's guardian able to do it for them? Is that the same kind of thing that you're talking about? Like, does that make sense?
Go ahead, Heather.
Okay. Yeah. So if there is a guardian of an adult in services, they are the ones who choose the services. What we always encourage is that they are doing that in tandem with the individual to the extent that the individual can make those decisions, right? And so self-direction will be an option for them as well. Again, those guardians, whether that's a guardian of a minor or guardians of adults, they will have to be that self-directed representative. They cannot be paid to provide that service. So, so those are things they'll have to take into consideration if that is something they're wanting to do.
So I'm just one other question real quick is like, so this would be possibly like it's it's like my daughter's waiver is very varied. Like I could not self-direct her day program, like that is something that I don't know how that would be. Like I could understand a respite program being self-directed, but I don't know how a day program, like, are you able to sort of do a combo deal?
Yeah, so day program isn't one of the options of services that would be self-directed. It's only those services that Holly covered, and those are really those personal care assistants or personal care type of services.
So your waiver could be partial self-directed and partial not.
Right. So like if your daughter's on, I'm sorry, your daughter, correct?
Yes. Yeah.
Okay. So if your daughter's on the FSW, you could self-direct her PAC services, but then she would still use the traditional model of day hab. And so that all still has to fall within your annual budget cap.
Gotcha. That's helpful. Thank you.
Thanks, Kim. Thanks, Heather. Kate?
Thank you. I would like to take this opportunity to put a plug in for supported decision making as part of those array of services, especially just connecting with Indiana Disability Rights for folks who can and want to manage their own services. Just ensuring that that is part of the conversation so that folks who maybe need assistance with managing their own services still have something in place to be able to do that. And Melissa, correct me if I'm wrong if this is not the right time to mention that, but I felt like that was the first thing I thought of when Kim was talking was we should probably include supported decision making in the conversation.
No, the principles match very well, and even as supported decision making is contemplated in Indiana law, supporters are not allowed to be paid service providers. So that certainly a supporter could be somebody who assists the person through that self-direction, because again, the principle is that they are there to support the person's decision themselves, not substitute the decision making for the person.
And so the only thing I would add to that is that, yes, you would have that supported decision-making team, but if they want to specifically help direct those self-directed services, they'd also have to be named as the self-directed representative. So you could be both.
Great feedback. Thank you all. Jim?
So I don't know if this is maybe a parking lot question, but I started to hear a bunch of questions. I don't want to miss this. I have a few that are based on the waiver amendments. So I don't know if we're just doing questions on the self-directed stuff and wait for the parking lot.
Yeah, let me
Okay.
see, Jim. Well, we're in the parking lot, so we're
Okay.
We're
Well,
at
I
the
just
very
I was
end
gonna
of
say,
it.
I
We're at the
think we're
very, very
comfortably
end,
in the
Jim. We're at the
parking
very
lot.
back of the parking lot of Target. Okay.
I
I'm just kidding, but let me double check, because before you move on, I want to make
sure.
that
That's
might have been the only question left about. I just didn't want to.
I think we covered the others.
Yeah, I think we
Jess,
did
I
too.
think.
Yep. Yeah. Go ahead.
Okay, so first of all, just a point of clarification, and I think the answer to this is I can't get access, but I just want to make perfectly clear. Is it possible for me to actually get access to the waiver amendments that were submitted? Just because I get a lot of questions about this on a weekly basis, and it's hard for me. I have to kind of go back to what was the original submission prior to public comment, but I don't have a copy of the ones that were submitted, the FSW and CIH. Is that something that I can get access to, or is that not?
Yeah, Jim, we will post them once they're approved by CMS.
Okay. That's what I
So,
thought
yeah,
the answer was. I just wanted to make
sure.
sure I got it right.
Sure.
So then that means that there are a couple questions because I don't know what was submitted. There are a couple questions, and the first one is about the school issue. So traditionally, behavior support, we can't be a para, for example. We don't go in and provide direct support, but we've always been allowed, and this is even in old waiver language, we've always been allowed to do to like coordinate with teachers, in some cases take part in an IEP meeting. Not go into the classroom and spend 4 hours with a kid. I get that. That's always been prohibited. And in the originally submitted waiver amendment, there was language that reflected that. It was very, very similar to the original waiver language that we've had in place for many years. And then there was a one sentence that said, all services in schools are prohibited. I did submit public comment on this saying this was inconsistent, but just for planning purposes, is it kind of the way it used to be, or is there a new prohibition against any service in schools?
Yeah, the expectation would remain that there would be collaboration and communication across settings, right? But the actual provision of the service cannot occur in the school setting.
So meaning we could attend a meeting, but we can't go and like start helping a kid.
Absolutely cannot provide that service. And yeah.
Okay. That's what I
absolutely.
thought.
And some of that will be a little more clear will be clear, I should say, when we issue some additional guidance around the new behavior support services configuration of things. So that'll be a little more clear then. I think, Jim.
Are you meaning quality guide when you say
yes,
more? Okay,
yeah,
thank you.
Yeah. I think our effort there is to draw a very clear line that we cannot provide behavior support,
right.
services in the school setting. Because there is appears to be not always a clear understanding of that. So
well, I answer that question a lot, so I know that you're right. Because people ask that a lot. And I would also like to just a quick comment, appreciate that I had been contacted by the person who's creating the quality guide and provided some feedback on some of the clinical supervision stuff that was from the IPP grant. So thank you for, I don't know how that all worked, but since the last meeting, I've actually provided some stuff and we've had some back and forth. And I think that will benefit future clinical supervisors. My last question though is, and this is really just a wording thing in the waiver amendment. And I think the answer is there was never any intent to tell people how to run their business. But there are a lot of behavior support providers who have contracted BCs. There are a lot that have salaried BCs or part-time BCs. And there is wording in the waiver amendments that includes that in order to be a BC, you have to be employed. That's the word, by an agency that's a provider. Employed is a very specific word and it means employment and it does not mean contracting. And it has caused some consternation among behavior support providers like, do we have to totally change our model? I kind of told them I think it would just meant, hey, you have to be part of an agency that's a provider,
Correct.
not necessarily employed. I just didn't think
Correct.
that you guys meant to say, oh, half of you guys have to change your model. Can we safely say that it's not employed?
Yes,
Thank
you are correct. We are not, our intent is not to change the ability
Okay.
that
That's
exists today.
That's what I thought. It's just, it's a pretty specific word. And, I know you guys submitted a 100 and something page document, one word, whatever, but I picked up on it because it's a specific word in employment law. So, thank you. That's all I got. Appreciate it.
Yeah. Lexi?
All done. Mute. Currently unmuted.
I had two questions for parking lot. My first is I myself, as well as a lot of other people that I know, for one reason or another, the amendment documentation that's usually like 75 pages long is just much too much. Is there a plan or is there already a way for like fact sheets to come out, like short, relatively short, not like just a couple paragraphs, but shorter than 75 pages? Is that available or can that become available? And then I have a second question after you answer that.
Yeah, Lexi, that's a great idea. And actually we're working on some fact sheets for when the waivers are when CMS finishes their review. So good call.
Perfect. And then my second question is, I just want to get some clarification. So from what I understand from some of my friends, there was like a pilot program out where very few people in the state had it, but it wasn't in regards to 24-hour supports. I think regarding like health and wellness waiver, and I heard that's coming to a close. Can you touch on that a little bit?
A pilot with the health and wellness waiver?
I think it was a pilot or something where like so many people in the state, like only a few people, but like people that really needed 24-hour care was getting it.
Holly, I believe she's talking about participant-directed home care service.
Oh, you're talking about a model of, thank you, Heather, because it wasn't ringing true or ringing the right bell in my brain. There is a very small number of individuals supported in a self-directed program today. But as I mentioned, they will, much like all of our self-direction that exists today, they will be rolled into the new model on December 31st, pending CMS approval, Lexi.
Okay. And will that limit them to like less than the 24-hour care? Because what I'm hearing is concern that people who are getting the 24-hour care will not.
It will be done as any other self-directed or traditional budget, so to speak. So any other budget, the services would be based on the assessed need.
Okay, I understand.
Okay.
Thank you so much.
Thank you, Lexi. Jess, I'm going to pass it back to you. I think we've gotten.
Let's see. I did post some data, some HCSP data, and I apologize. Kelly and I have talked about this morning about showing it, and I didn't, of course, because I forgot. But just some data of how many people have been granted certificates. And then I thought that was kind of interesting, the most active day of the week. And then a lot of folks using their mobile device, which I think is not surprising, but pretty cool that we're seeing that, and we haven't received any really feedback that that doesn't work well. So excited to see that. And then Kate, I think you had a question about the public comment. So with this board, this is we don't have any delegated authority within the DDRS Advisory Council. So the goal and the legislative mandate, I don't know if that's the right word, but is that you're representing, right, a certain group of stakeholders or within your agency, or if you're, and even if you're a self-advocate, right, representative, you're representing self-advocates. So this wouldn't be an avenue where there would be any sort of public comment. Does that help? Got it. Okay. Okay, let me just double check. Sorry, I'm kind of getting through here. Okay, I think we've got most of everything. Next meeting, November.
Jess,
Oh yeah.
can I do just one other
Kelly, go ahead.
reminder?
Yep.
If folks are signed up for FSSA or listserv, you will get a notice, but our next quarterly financial review is scheduled for Wednesday, October the 29th in the Government Center South in the auditorium. And I believe DDRS is in the afternoon. I'm not looking at it. Sorry. I think we're at 1 o'clock. We're immediately following lunch. So we have changed time. We were earlier in the day. So let me check. Yes, DDARS starts at 1. We're from 1 to 2:15.
Awesome. Yeah, that will go out through the listserv. You think, Kelly, soon? I'm guessing soon.
It
right?
actually went out. I have it in my
today.
inbox.
Oh, did it go
So
today? Okay.
I just wanted to highlight that, and my apologies. This is my oversight. I would have put that in a bullet here, and I don't know, it slipped my mind. So my apologies to all. So.
Great. Okay. And our next meeting, we are meeting in a month. Normally we're doing every other month. This was a date we already had on the calendar, and since we wouldn't be meeting, there's a lot going on, so I don't think it as much as Holly. I know Holly just wants to keep talking, but but Beads is up, so I would think it's probably not going to be 2 hours. It will be scheduled for 2 hours in that conference, or 3 hours, I'm sorry, just because we just did meet. But just as an FYI, it's possible that will end before 12:30, but we will set it for that long and obviously have an agenda. And that will be in person. So, all right. Well, hope everyone has a great rest of your week and enjoys the rest of October and the fall weather.
Enjoy the beautiful day. Thank you.
Take care, everyone.
Great job. Thanks for all the questions and input.
Thanks.
Thank you.